Hello, and welcome to episode 8 of the Auditing Antics podcast. So, today we're going to be going over Incident 2. And this is something that, is definitely talked a lot about in the industry. But for as much as we are constantly talking about it, it is really, unfortunate, I guess I will say, to see how much this is still being used and used incorrectly. So, we really want to do a deep dive today, talk about the specifics, talk about, a lot of the problems that still exist. And Michelle, I find that one of the biggest issues with this, whenever I'm asked by a client about incident 2, say, for example, if they're not doing it yet, or if they're starting up a practice, things like that. They'll say, okay, well, what about incident 2? Can I get paid at 100% of the physician fee schedule? And that's the extent of the knowledge that they have around the concept.
Mhm,
So, that question right there is the base of a lot of issues that tend to exist in practices. And, it's one of those things too where I personally cannot say that to this date, for all of these years, I've audited a practice on incident 2, and the first time I've reviewed it, there is accuracy. There's usually full of, all kinds of errors. So what are
mhm.
your thoughts on that from, the concept of just focusing on money?
Well, I think it's really concerning because I do think that a lot of people implement the incident to model into their practice so that they can get that 100% payment. And I think that when we're looking at incident 2, the focus definitely should not be on the payment side of things, and it should be on the compliance side. And I think if more people focused on compliance over payment when it comes to incident 2, they would find that it's just not worth it, because the amount of times that incident 2 is actually supported is quite minimal when we actually get down to it and look at these encounters and look at the documentation. So I think that there needs to be this shift in thought process, and really you need to focus on compliance, because when there is compliance, you will have your payment. So just because you're billing incident 2 and it's getting paid and you're not seeing any denials or anything doesn't mean you're doing it correctly, because the payers aren't necessarily looking at the documentation to verify that incident 2 is supported. Um, so I think that's something that, really, if this is something your practice is doing, you kind of need to take a step back and look at the overall picture, review your documentation, review your workflows within the office, and make sure that these services are actually supporting incident 2. And I think it would be pretty eye-opening if practices who are currently using this model did an audit. I think it would be extremely eye-opening to them as to the level of non-compliance that is happening surrounding these services.
Well, and some of the issues too is if we think about the structure of organizations now, there's more and more clients that I work with, whether they're a small individual private owned practice, a large multi specialty group, or hospital systems, entire facilities that are no longer looking or employing coders who are looking at all of these claims. So, what that means from a compliance standpoint is that it puts that burden over to the provider. And then
Hmm.
also, there's times I feel like concepts like this fall through the cracks because there are always, a billing team. So we always have a revenue team who's looking at charge entry and things like that. But we also have to remember, and I know we've discussed before, what is the amount of education that they're receiving? What are the resources that they are receiving? And, when we have this disconnect, that's where a lot of times that compliance oversight is not happening. And it's
Hmm.
really important for incident 2 to have that. Now, I have some specific examples I want to go through, but I want to touch base on the different rules of incident 2 because there are some areas that I think some people still forget about when we talk about this concept. So, first and foremost, we need to remember that Incident 2 is a CMS guideline. So,
Mhm.
what that means is that we have to look to the commercial payers to see if this is even something that they're going to allow or follow. And, there's a lot of confusion as well, even for myself when I dive in from the defense standpoint. There are times where I will see that a commercial payer, for example, will default to CMS, but we don't always have that in writing. We don't have something definitive that we can look at. Sometimes that's only a verbal directive that's being given internally. So,
Mhm.
we have to look to see if there are incident to policies. Those do exist in some places. The one
Yes.
that stands out to me is Blue Cross Blue Shield in Texas. I haven't dealt with it in over a year, but they had an actual documented policy for incident two, how it plays into what they wanted with the SA modifier and all of that. Now, in addition to that, a lot of people will think, okay, well, this is going to be a replacement for credentialing. Well, over the years, yeah, we had trouble there because some of the payers would not credential our APP practitioners. But if we look at the model now and the commercial payers now, that has also gone away where they are having the practices come in and credential and enroll the APP providers just like they do the physicians.
Mhm.
For me, currently, the only larger commercial payer I'm aware of that does not credential APP practitioners is Cigna. Now, sometimes there's various Medicaid plans that still will not credential in that way, but largely it's going to be Cigna and everyone else, United Healthcare, Blue Cross Blue Shield, all of these other large payers got on the bandwagon and they now credential and enroll those practitioners. So it's not a replacement for that. And that's something too that when I find issues, one of my questions is when I know someone is billing incident to across the board, which we'll get to a little later, but across the board, if everything going out the door is incident two, my main concern and first question is what does their credentialing and enrollment look like for those people? It cannot just be under the physician across the board. Now, another area, and Michelle, I know that you have seen this in audits as well. Another area that a lot of people forget about is that CMS talks about the fact that, yes, the physician has to create that initial treatment plan, but in addition to that, we have to make sure that they are continually staying involved and showing that they are an active part of the care for the patient. Now, with that being said, they don't give us a time frame as to when the
Mhm.
physician has to, go and see the patient again. It should be led by things like exacerbations or acute problems, but they
Mhm.
don't give us a time frame that we can stick to and say, okay, at this time the physician must also see the patient independently. And I've audited some practices where I see it in two ways. I see it one where an APP, let's say a nurse practitioner is seeing the patient and they just put in there that they verbally discussed with the physician their plan and the physician agrees. That's not going to cover
Mhm.
ongoing physician involvement. And for me, I personally recommend the physician seeing a patient again independently. Remember,
Mhm.
split shared services are not a thing in the outpatient setting. So I really think that the physician should see the patient at least once a year. So we have a metric that we can look at. We can see if we have that compliance and we can apply it. Now, that can be determined internally as a policy and how every practice and facility wants to do that. My recommendation is always at least once a year.
Mhm.
Now, Michelle, can you speak to that some as well? Because I know, if we look back in a chart, sometimes a physician hasn't seen a patient in 3 years, or they've been seen as a new patient by an APP provider, and they've
Mhm.
never seen the physician independently.
Yeah, so I think that when I'm auditing these services specifically, you do have to look at the overall picture. It's not just about what's in that chart note for that day. I think what I see most commonly is, like you said, this attestation statement within the note, either from the APP or the provider saying that they've discussed the patient and they think that this magically covers them for oversight. And then when I'm looking back in the chart, like you've said, it's been years since the provider has seen the patient, or months and months and months, and they have been subsequently seeing the APP. And as you start looking back at this, you see, okay, so 3 visits ago, this patient had an acute complaint, and the APP initiated this treatment plan that they're now still continuing to this day. And it can get pretty involved and intricate as to of where and when incident 2 is no longer supported. So just because it appears today they are continuing a treatment plan, who put that treatment plan into place is one thing that you have to ask yourself. So you have to be really diligent to make sure that you're reviewing these encounters for compliance. And if you're doing an audit on incident 2, or you're doing some type of review where incident 2 comes up, you also have to go back and be validating everything that's happened before, because along the way you're going to find where that chain has broken. And if that new, that new problem or new treatment plan has been put into place and that patient wasn't independently seen by the provider, incident 2 no longer is supported with those encounters, because continuing your own treatment plan that you developed is not the definition of incident 2 for an APP. So I think there's a lot of diligence that goes along with ensuring compliance in these, and it's a lot more work, I think, than people sometimes realize. That retro review, not just looking at the note in front of you, but what has been happening since they saw the provider. Like you said, did they even see the provider? I can't tell you how many times I am auditing a an incident to encounter, and when I go back, they've never seen the provider at all. They are were a new patient under the APP and just continue to see the APP with that attestation, a lot of times saying that it's been discussed, but there's never been um that independent encounter with the physician to develop that treatment plan that the APP is supposed to then continue under the direction of the provider. So I think that a lot of times that part is missed, and that's my little soapbox with incident 2, and why it's just not a good idea, because a lot of times people aren't willing to put in the work, or don't know they need to. I shouldn't say they aren't willing, but don't know that it's necessary to go to that extent to be validating incident 2 as compliant.
Or really the sources as well,
Hmm.
because one of the things I've been thinking through as you're explaining that is the whole workflow is broken as well. And
Yes.
that's something that I find when people don't understand this, or they only focus on the revenue side. When we look at the workflow, for example, if we're looking at the scheduling of a physician and all of the APPs in a practice, usually the physician has just as busy of a schedule as everybody else,
Hmm.
if not more. And it wouldn't even really allow them to take over that encounter. Because remember, like you said, Michelle, it's something where it's not the validation of communication. That
Yes.
physician has to go in the exam room, take over the encounter. And, one of the things that I teach around this is taking over doesn't mean then handing it back to the APP provider to document everything, put all the orders in, all of
Yes.
those things. It's taking over that encounter just like you are independently performing the initial encounter.
Hmm.
So, a lot of times that alone does not work from a workflow perspective. And then also, I find sometimes as well that the billing staff, for example, they don't going back to what I said before, they don't fully understand what it means. And
Mhm.
fairly, it is not their job to be going in and looking at every record like a coder
No.
would to scrutinize it and validate whether or not it's appropriate. So sometimes when I've seen issues with this, we go back and, try to dig through the weeds of the process to see how it's happening or who has a misunderstanding. And there's been many times where it's someone who works in the practice who does the charge entry, and they've been told since they started to always bill under the physician. They don't even know that this whole other concept exists and that it's a problem. And sometimes what I find too is that, going back to the point of not having coders who are reviewing everything, when I work through these issues, there are compliance departments who are very strong in their knowledge, who know exactly what's going on. But to your point, Michelle, from a resource perspective or just a cost of employment and
Mhm.
staff and responsibilities, they don't have the capability to go in and do all of this validation. So even though we have the knowledge, there's still a large breakdown and there's a compliance problem.
Yes.
So
And and
go ahead.
another thing that I think of is how many times do you do a provider audit where incident 2 is a factor and then you go meet with that physician and they have no clue that this is even going on. Like,
Oh, I have a funny story actually. So sometimes when I meet with physicians, they will actually say to me, I have no idea why you're talking to me about this encounter. That's so and so's patient.
yeah.
And it's because we pull up the billing provider in
Mhm.
an audit to pull a sample, and it's all coming up under the physician. And they're like, why are you asking me about this? This isn't even my work. And it's like, that's my point.
Yeah, exactly. And it's something that providers should be just as concerned about because it's being billed out under their name. They will be impacted from the non-compliance of billing incident 2. So I think it's not something that is left to it's everybody's responsibility is I guess what I'm trying to get at. The provider needs to make sure, it sounds good to get that 100% reimbursement, but the provider needs to make sure that what's being billed under their own name is being billed appropriately and supported by documentation and the workflow necessary. I think that it's the responsibility of the coders as well as the office management and administration to recognize that this doesn't fall on the billing staff to validate, and it's not a good compliance plan to say we're just not going to review any of it because we don't want to employ coders. And so I think there's a lot of people who have to take responsibility for for how incident 2 is implemented and how it's monitored and the oversight of that.
Well, and that also makes me think about, practice managers, for example. They have a lot on their plate already, and there is a
Hmm.
lot of different areas they need to be aware of. In our position, we can focus on compliance only. They're, having to look at, okay, yes, the compliance side, but is the clinical side running appropriately
Hmm.
and all of those things. And, sometimes I find that it's also an issue when management doesn't understand the specifics of compliance, which
Yes.
again, this is why audits and external audits are so valuable and needed because there's so much going on that, it would be pretty impossible unless somebody focuses only on this to know every single thing,
Hmm.
especially if they're in a position of management and that's not their main concern.
Hmm.
So I want to throw that out there because I don't want it to seem like I'm blaming managers at all
No.
because I'm fully aware of everything that they are having to juggle. But I bring this up because there's times too where they're thinking, for example, one of the issues I had to work through with rheumatology is that, you have the infusion suites that go along with the outpatient practices.
Mhm.
And within that, it will fully depend on the model structure from a payment perspective as to how the physicians are paid, for example. But a lot of times there may be bonuses related to
Mhm.
RVUs, or maybe salary in general is based on RVUs to some extent. So, where this ties into incident two and becomes a problem is that a lot of the times, if they are ordering infusion services for their patients, they want to be able to receive that RVU credit at the time that that is done. But what happens is a lot of the practices will implement a process where whoever orders it gets to automatically be the one to bill it. But when
Mhm.
we think about incident two and all of those things that play into it, they're not always the one who's physically there on
Yes.
site. And, there can be scheduling issues. It could be a provider's preference. So, what I mean by that is I had a physician who didn't step foot in the office until 9:30 every day, but yet their infusion started at 7 a.m. every day.
Oh boy.
So things like that are going to be an issue too. And when we're talking about incident two from this perspective, just to be clear here, it's not necessarily billing APP services under the physician, but there are different items that take place or different services that are rendered that still fall under incident two guidelines,
Mhm.
where we ultimately are seeing the physician's name and NPI number on that claim form. And that's where we really need to focus and make sure that everything's on par and, okay in that situation.
Yeah.
Now, this is something too where sometimes you even have to bring finance in, because if it's a matter of a physician wanting to receive credit for the infusion services, they are monitoring from a treatment perspective. They are monitoring labs. They're making sure that there's no toxic effect from medications. They are adjusting the other treatment the patient has. So, in general, if we think about the treatment of the patient overall, they are doing that. But on the individual days of the infusion, they may not be the one there with the direct on site supervision. So,
Yes.
when I say finance, sometimes what I suggest there is there's ways to track the information on the backside, and
Mhm.
finance can make sure that the provider is appropriately credited for the work, the RVU, but not from a reimbursement perspective, not from a perspective of what goes out on the claim.
Yeah.
And again, as you can see, that goes pretty deep. So
Yeah.
if people don't know about incident two to begin with, they're not even going to know all of this can be a problem as well.
Yeah. So I think that's something that when they're determining that financial side of things, a lot of times they don't look to that as a solution because there is a lot of background work that has to be done, and it's just easier from a scheduling perspective to say this provider ordered it, this is the one we'll bill it under, and the system allows it to go through nicely, instead of actually looking at who's doing the supervision of the service and then figuring out the process that works out for whatever financial goals or things like that your providers have related to their work RVUs and everything like that on the back end. Um, I think that it's often a process that, when you have to do more work, it's going to be
Yeah,
looked at like,
it's going to go on
I've
the
already
back
got enough
burner.
to do. And unfortunately, sometimes we can't approach things from that perspective of we already have enough to do, we have so much that we have on our plate already. Sometimes we just have to buckle up, take take what we have to take and what we have to do. And
Or don't do incident two.
exactly, or just don't do it. I think that's the easiest thing for everybody. What is that 15% worth? At the end of the day,
In
when
the
you're having
future.
to do
Yeah.
all of these different things, well, what is it worth? You have to look at, from the office visit perspectives. What does that equate to? compared to the amount of time and administrative burden and cost that this is putting or should be putting on your practice if you're going to ensure that you're doing incident to correctly. And I think that's why a lot of times when compliance individuals talk about incident to, they're like, nope, nope, don't even go there. And I think then you get administration who's like, well, this is a missed revenue opportunity. And there's a lot of pushback from leadership and administration on as to why aren't we taking advantage of this 15% when, like you said, they have no clue. So sometimes I think that that's a factor in it as well, is that pushback you receive on why you're not taking advantage, I use that lightly, of that extra 15%.
Well, and one of the problems too, so when I complete my audit reviews, sometimes they do result in me needing to see if they have a health law attorney,
Hmm.
telling them we really should engage them in the next conversations we need to have, because there are times, especially if they've not credentialed the APP providers and done that enrollment process, if they have just across the board, like for example, in urgent care, that really
Hmm.
would not make sense in an urgent care. Or,
No.
I talked some about rheumatology, and the thing that's difficult with some of these specialties is that the patients are constantly experiencing new issues, new pains, new
Hmm.
problems in different anatomic locations. Same with pain management. So the question becomes, okay, are we going to skirt the line and say that, a physician could write one treatment plan and say, if this, then all of these other things will
Yeah.
happen? But then I think back to the defense work that I do. And, one of the things that we often have to look at when we are doing appeals and rebuttals and all of that is when there is more of like this treatment plan that is not individualized to the patient on the date of
Hmm.
service. And that still becomes a problem that you potentially have to argue back against. So that I personally do not recommend that, because I feel
Hmm.
like it's going to put people in a place where they're going to have to potentially defend themselves, and to me, that compliance risk goes higher in that situation.
Hmm. Yeah, because then at that point you're looking at, now you've used this canned type of documentation across all of your patients and everything is starting to look the same. So you have patients coming in with different conditions, but their treatment plans are all looking the same with this, if this do that, if this do that, if this do that. And how can you even tell ahead of time, is my question, what would be appropriate for that exacerbation or new problem or complication that could arise? I feel like that's something that you would have to evaluate the patient. Like, that's the whole reason why they're saying if a new problem arises, the provider needs to independently see the patient and develop a new treatment plan for that new problem. Because I don't think that you can across the board say this would be the appropriate treatment for the patient should this issue arise. What are your thoughts
Yeah.
thoughts on it from that perspective? That might be getting a little bit clinical, but I think back
Yeah.
to just all the notes that I review. Like, I've been working a lot on ortho right now, and it seems like patients come in with different problems, different exacerbations, and I don't see the provider prescribing the same treatment across the board for, even when it's two patients with osteoarthritis of their knees. They might be doing different things based on the individual needs of that patient or the individual comorbidities of that patient. So I find it interesting that some might take that method of trying to, like, develop this treatment plan ahead of time that could be this moving treatment plan, and anticipate what the changing needs of this patient may be from that initial visit.
Yeah. Well, and that's a really good question, and I have some insight, but I'm going to preface this by saying it's not my own clinical insight. I actually, when I have to meet with practices, with physicians, and do education and talk through audit results, I'm always looking to learn from them as well, right? Because
Yes.
we need to know their thought process clinically to try and bridge this gap that exists between compliance on the coding and billing side and the clinical side. So I find it interesting you bring that up, because I think
Hmm.
what they are trying to do in that situation and their thought process clinically is that with certain conditions, let's just say certain diagnoses, there is
Hmm.
what would be a standard protocol. So maybe they personally have standard protocol for, arthritis of the knees or whatever the condition may be.
Yeah.
But to your point, the reason that doesn't work, even though they may have standard protocols that they follow as a baseline, deviate as necessary to the patient, is that when they're documenting a plan, we'll say based on standard protocol, it still doesn't get to the point and the fact that E&M services are intended to be based on where the patient is that day.
Yeah.
We
Yes.
can't bill because we can't bill today with the fact that a patient with left knee arthritis could need a total knee replacement in a year or two. We can't
Hmm.
look at that from a coding perspective. So I think that's where the disconnect is. That is absolutely why I'm not comfortable with it. I don't teach that way. I don't,
Hmm.
suggest to implement that way, because that's really going to start to muddy the waters, and it becomes really difficult to come back after the fact and talk about how at that moment you could make the decision about the future, to your point.
Yeah. Yeah. And that was just something that when you were talking about that statement, I was like, how does that even work? I mean, I understand that there's certain protocols, but each patient is individual at the end of the day. And I think that's a point we try to get across to our providers on a regular basis is that you have to show how you uniquely
Yeah.
addressed this patient's problems because while some patients will experience similar things, not every patient is going to fall into this bubble,
Mhm.
this
Yeah.
certain category or this template you want to use. And that's why they should just be used for guidelines and not like strict replacement of
Yeah.
documentation.
Now, getting back to workflow, there's one other
Mhm.
area I want to go over, because there's another common misunderstanding that I get asked about a lot during audit education sessions, where there's not full compliant understanding about differences between Incident 2 and split shared services.
Yes.
So, to simply explain, Incident 2 exists in the outpatient office-based setting, and if we look to split shared, I always like to pair that more with a facility based setting,
Hmm.
right? So we have
Yes.
inpatient, we have observation, we may have quote unquote outpatient practices, but they're physically located in a hospital where they have place of service 22. That would
Hmm.
still be split shared services. So one of the things that I find is that some physicians are thinking about the fact that yes, Incident 2 exists, but they want to fit it into a split shared model.
Yeah.
So, for example, I believe it was a year or two ago, I was working with a hospital facility and we had issues with this particular outpatient, again, private practice, place of service 11, and the problem was they were essentially hiring physician assistants to help them with patients, but they weren't allowing them to take over an entire encounter and treat a patient on their own. And it became this whole thing because they were wanting to do split shared and bill it
Hmm.
all under their own. But there were many times that with the physician assistant, the patient was exacerbated, they had brand new complaints. X-rays were having to be ordered. All of these things were being done to address a change in the patient. And because the physician wanted the PA to also do all of the documentation, we had no idea what was going on. From what I would call a surface level looking at documentation, it looks as if the PA is doing all of the work. And
Uh-huh.
then we meet with the physician and they're like, No, they don't do that. And, at one point I had even met with a physician, and honestly, it frustrated me because I felt like they were, really looking down on other practitioners. But, one physician's complaint and frustration is that they don't even trust a PA to ever make
Yeah.
decisions about a patient. So
Yeah.
then the question is, okay, why do you have them in your practice?
Mhm.
Do you know that if they're a scribe, which they can't just be a scribe, that they also cannot perform any portion of this encounter for you? You
Mhm.
need to go through all of those steps, and you have an expensive scribe, which we
Yeah.
know is not happening. And to me, in one of the sessions that I have, I remember thinking and communicating after, we've got to escalate this particular practitioner and group in a facility up to a higher level of a compliance concern, because they just kept saying, really, frustrated, okay, this is a scribe. This is a scribe. And every time we tried to talk through it, they just came back with that. And, we know in that situation, it's not what's taking place, it's
No,
not the
yeah.
performance. And, like I said, at the end of the day, split shared is never going to work. It goes back to what we said earlier on with that phrase that they try to insert into notes that they've discussed with a physician.
Yeah.
Well, even if we go a step further and we think about, for me, what I think of in my work is legal scope of practice.
Mhm.
So that, let's say with a PA and NP, they're legally acting within their scope of practice. They
Yep.
have to have that collaborating physician who's supervising and helping and gives that practitioner the ability to have those conversations, collaborate on
Mhm.
diagnosis and treatment. So that doesn't automatically make it incident two. It doesn't fit into a split shared bucket. But, in general, that's a whole other concept that leads into the problems that we're seeing on a regular basis.
Yeah. And I've seen that a couple of times, come across that a couple of times, and then they try to backtrack and say, well, they're a scribe. And it's like, well, it would not appear that they are acting as a scribe because they
And that's
performed the physical
offensive.
exam.
Yeah, if
And
you think professionally, that's very
yes,
offensive as
they
well.
didn't do all of that training and schooling to be a scribe. Not that, not to take away from the work of a scribe, but when you look at the schooling that a physician assistant or a nurse practitioner has to go to, they have to get that higher level of education to be able to perform those services. And like you said, that's within their scope of practice. So when you're looking at the cost of that oversight, the cost of that collaboration, that's just something that goes along with employing an APP within your practice. It's not necessarily an opportunity to make more money off of them. You get that from them establishing their own practice with the oversight and collaboration of the physician. And it's not a way to like extend the revenue of the physician, but allow them to establish their own practice within the facility, with your own practice. And I think a lot
Yeah.
of times that's not what or how people consider an APP when they're bringing them in.
Yeah. Well, and for today, I want to actually go into this last topic here
Mhm.
related to the data analytics side of things. So, one of the things that I think of is, even if I don't have software that does all of that and gathers the data for me, as a consultant, as an auditor, as a reviewer, I can take information, even just in an Excel spreadsheet, and identify where there potentially is a problem.
Mhm.
And
Yes.
something that people really need to be realizing is that as you send these claims out, these claims are going to paint a picture about what you're doing from that workflow perspective, whether you realize it or not. So if we have a physician, and I've had this happen too, this is an extreme example, but we all know these things can happen. I've had a physician who was practicing in one location themselves personally. They had APPs with them in that one, we'll say practice A. All of them were billing under the physician. We had practice B at a completely separate location, nowhere near practice A, and a practice C. The physician was billing all of those things. So
Yeah.
we've got not only a volume, a high volume going out under one physician's NPI number, we have multiple different locations. And then, even if we don't look at notes, we're going to be questioning a medically possible day, right? So, CMS and others, when there's investigations happening, they're going to look to say, okay, is this even humanly possible that the physician did the work? Now, one thing we didn't touch base, and I don't think we need to heavily do that today, is the fact that the physician has to physically be there if they want to be the one to bill. So, like
Yes.
we did talk about it with infusions, but applying it in with our APP practitioners, that physician has to physically be there in the office suite. They don't have to be in the exam room, but that physician cannot be in three separate locations at the same time
No.
and have their own patients schedule themselves personally. So,
Correct.
from a data perspective, I bring this up because if you are managing, for example, a smaller practice, start to run some of the reports from your
Hmm.
practice management system. Look to see just what your claims are showing, and make sure to, when you're pulling audit samples, for example, you want to be able to identify the billing practitioner and the rendering practitioner. And
Hmm.
this is something too, when I go into audits with new clients, I always ask up front if we're in the office setting, if they do incident two. If we're in facility, I want to know if they're billing split shared.
Yeah.
If the answer to that is yes, or they don't know, when they pull the reports, I need those two identifiers on there so we can start to see if just visually there is a concern we need to dig into from there.
Hmm.
So, it can be done on a smaller level. I definitely suggest having external audits done. That's something that I have extensive experience in from an audit perspective, from a defense perspective, education, all of those. And, obviously, owning the consulting firm like I do, I'm a large advocate for these external reviews. But we have to remember it's not just a matter of who has the knowledge inside of your organization. The other question to ask is who else is in charge or in admin level positions that are suppressing the person who knows that this is potentially wrong. And
Hmm.
that's the type of thing when you get an objective third party coming in, those things can be worked through. If the person's been telling the group for 3 years that this is a problem, okay, that,
Yes.
hopefully they're not still working there after 3 years and knowing this is happening. But
Yeah.
there needs to be other support and other input, and there's a lot of different ways that can look as well.
Hmm.
But I say all of that to say that, the main point of the episode today is that we don't look at incident two just as dollar signs.
Hmm.
As you can see, we've been talking for almost 45 minutes and there's a lot that goes into it. So you've got to get on top of this. If you don't know if your group is doing this in any way, you need to have an audit that needs to be looked at. And
Yes.
we've got to validate, whether or not this is compliant. And like I said in the beginning, usually it's not. And usually the outcome is, okay, we need to look at dismantling this billing
Hmm.
process. Or if you're going to do it compliantly, what do you have to commit to from a time and a cost perspective to
Yes.
implement the proper oversight of that type of program?
Yes. And I think that's something that is also important to note, which we haven't talked about today. We incident two is as important as ever, not just because historically it's just not been billed in a compliant manner, but the OIG has now added this to their work plan. So it's something that they're going to be looking at specifically. So when you're talking about this like analytic side of things and the data, they're going to start looking at these outliers, and the payers and CMS, they're going to be able to easily identify who is utilizing incident two, and then they're going to see some of the, some of this data that comes through and be like, interesting, this provider is billing at 3 different locations on this date as if they worked a full day at these 3 different locations. So it's really important to note that this is also on the OIG work plan. So that's why it is even more important that practices are looking at these workflows, identify, are services being billed incident to? If you don't know, you should figure that out pretty quickly. And then, are they being billed compliantly?
Yep. All right, so we'll go ahead and end the episode here. And I do just want to remind everybody, I do have, like I said, the consulting firm. So as a part of that, with the services that I offer, there are the audit-based services where we can go in either retrospectively or prospectively, take a look at what your claims are looking like, your level of compliance risk. And there is also opportunity for things like revenue cycle reviews. Today, talking about incident two, that's another thing that is often uncovered under a revenue cycle review. And also education services. You know, if you're looking for different subjects to be talked over with a group of providers or compliance staff, coding, billing, whatever it may be, we can really customize to whatever it is that you need at the time that you're looking for help. Lastly, we do also have the Coding Compliance Connection membership. So there are a lot of resources on there. I do actually have an incident to guide to make sure that you're following that appropriately internally. And, there's other services involved, like being able to ask questions on a regular basis and some live events, things like that. So thank you for joining us today. And one last item. So I've been pushing it out on social media, but regardless of the platform you listen to us on, if you could go in and like this episode, subscribe to the show, share the show, maybe leave a review. All of those things are definitely helping. I can see that our audience is growing, and I'd love to continue to get that out there. So please go in, do that when you think about it, when you're listening, and that would help a lot. Thank you.
Bye.